Thank you very much, Sanjay and your team for calling me over for this meeting. Coming to MP is always a homecoming for me since I left this state way back in 1980 to pursue my career from Jabalpur. Anyway, so he's given me a very interesting talk, and that is on liver metastasis with occult primary. So liver is the most common cause for metastasis after the lymph nodes. And various studies have shown that you can identify the primary in about 27% of cases in one series, 73% in another autopsy series, and yet another series about 74%, with colon being the commonest in some, lung, pancreas, breast, etc. So there would still be a group. What I'm going to talk to about is the group in which you have not been able to find out the primary. And this is in short known as carcinoma of unknown primary. This is a heterogeneous group of liver metastasis where no primary site is identified despite a thorough clinical, radiographic and endoscopic evaluation. The common origin for this occult primary is usually from the lungs, which remains undetected, kidneys, pancreas, colon, and breast. And the primary in such situations is microscopic in size, and for some reason, either because of the environment or the absence of neogenesis, the size does not increase and it doesn't show a malignant transformation. So isolated liver metastasis is seen in about 38% of cases, but usually in 62% you may find sites which are very small and undetected. What's happened? So these metastases in the liver could be solitary, they could be multiple. Very often they are aggressive, and when you do a histology of them, most of these have adenocarcinoma in about 58 to 79%. Some of them are poorly differentiated or undifferentiated carcinomas. Some turn out to be neuroendocrinal tumors and some squamous cell carcinomas in decreasing order. The survival after liver metastasis with primary being unknown is about 3 to 9 months, mainly seen in males, and the age of diagnosis is usually 61 to 65 years. But it's absolutely important to differentiate these cases from primary hepatocellular carcinoma because the prognosis is different and the management is also different. So how do you approach to such a patient with an unknown primary? Patient history is absolutely important, and you have to ask questions specific to the signs and symptoms of different organs of the body. Any prior intervention has been done, past medical or family history, and do a good thorough examination of the thyroid, breast, pelvis, prostate, and PR in both the sexes. Blood samples which would help you would be raised LDH, which usually is seen in malignancies, more often with hematopoietic malignancies, prostate-specific antigen, HCG, and alpha-fetoprotein. We also do CEA and CA125, but they lack specificity. Fecal occult blood needs to be done, urine analysis needs to be done, X-ray chest and CT chest, abdomen and pelvis, mammography, and even MR enteroclysis may have to be done in these patients to come to a conclusion of where the primary has appeared. Endoscopy may help in some cases, but you would necessarily do it, and colonoscopy also is indicated, especially if the metastases are isolated and they are amenable to resection. If there are bone lesions, one would suspect in elderly males, probably coming from the prostate. PSA needs to be done, testicular ultrasound needs to be done, germ cell tumor markers, mammography. apart from the other common usual malignancies that we see. The CT abdomen and pelvis that is done should have thin slices with IV and oral contrast, and these slices should be 4 to 7 millimeters, which usually is done with the multi-detector CT now in usual clinical practice. Some have also advocated whole body MRI because it doesn't give you an exposure to radiation, but it is expensive and it's better in revealing bone metastasis to the spine, pelvis and femur, and you may have to resort to bone scintigraphy. So you see, you have to undergo so many tests to pick up a primary in such situations. Something which has become very popular is the FDG PET, but this has limited value in squamous cell carcinoma. It's important in neuroendocrine tumors when you will have to do a DOTA PET or somatostatin receptor scintigraphy. It has some disadvantages because it can pick up inflammatory lesions also and give you a false positive result. That is why the true positive is about 76%, false positive is 7%, true negative is 6%, and false negative is 9%. So usually the primary tumor sites in this particular study showed from GI and the lungs. But what is most important is doing an FNA of the lesion, either ultrasound guided, CT or EUS guided, and you can do a core biopsy with TrueCut or a FNAC with a needle. Usually you should have a 90% adequate tissue sampling, and this would all depend on the lesion site, depth, location, proximity to the vital structures, etc. And it has been shown, we always felt that fine needle aspiration is less sensitive to biopsy, but this particular study has shown that FNA sample was 2 to 24% more sensitive than the needle core biopsy. So you do a usual H&E staining, do some specific immunohistochemical stains for tumor linkage, and exclude tumors of non-epithelial origin which can be managed separately. And now people are doing gene expression and molecular profiling and gene microarray with target killing. So if you get a squamous cell carcinoma, think on histology, think of pulmonary, esophageal, head and neck, genital, anorectal, and immunohistochemical is of not much use. So do a meticulous examination of head and neck and all these organs which I have just mentioned, which would help you to come to a conclusion for the primary malignancy. If there is a neuroendocrine tumor, you need to do histochemical stains also for synaptophysin and chromogranin. But if adenocarcinomas are detected, which is most common, you should do a CK7 or CK20 immunostaining, because that would tell you whether the lesion is coming from the upper GI or the lower GI tract, cholangiocarcinoma, pancreas, lungs, ovaries and breast, or urothelial carcinoma. And you may have to do additional markers like CK17 for ampullary and pancreatic tumors, TTF1 for non-mucinous pulmonary adenocarcinoma, estrogen receptors, and always differentiate HCC from cholangiocarcinoma with Hep-PAR immunostaining. So, as I said, there's a huge list of investigations that you need to do. It's very time-consuming, expensive, and exhausting if you cannot get a clinical clue. But one has to identify the favorable subgroups. If it is adenocarcinoma and it's a female with peritoneal metastasis, one may have a good response. Women with axillary lymph node metastasis, men with elevated PSA, and metastasis with a single peripheral lymph node. These are the group of patients which have been studied and who are treatable. Squamous cell carcinoma, cervical lymph node if it is there, and inguinal lymph nodes for anorectal and pelvis primaries. And if it is poorly differentiated, young men with mediastinal or retroperitoneal lymph nodes, or NET. Prognosis is usually poor, especially if there is hypoalbuminemia, lymphopenia, if there is increased LDH, which is a measure of tissue damage, comorbidities, adrenal involvement, and poor performance status. And overall, these types of patients have an aggressive approach, except if they have neuroendocrine tumor on histology. So what is the hypothesis? Why is there no primary seen in a significant number of patients? It is, the primary is of small size, it lacks sufficient angiogenesis, and some of the cells migrate to distant organs, and liver could be one of them, which forms a new environment, and the angiogenic support is there. Why these patients are usually have an aggressive disease is possibly due to chromosomal instability. But it's usually important to have a primary site important, because if you can treat the primary site which you identify on histology, you may have a better prognosis. But studies have shown that traditionally, if you're not able to come to a conclusion, when you give targeted, non-targeted cytotoxic chemotherapy based on platinum, which is usually given, the response is very poor. And now you have molecular characterization, which is being now done in some centers in the country. People have used CT-guided interstitial brachytherapy. Some emerging role of immunotherapy has also been studied, and nanoparticle delivery of microRNA for colorectal carcinoma and liver metastasis has been shown. So this is a field which is now becoming more and more interesting for the oncologists, and occasionally the search is futile, expensive, and time consuming. Gene sequencing has improved survival. It is important to determine the site of origin, and there is a game-changing concept. So in conclusion, I would say that identifying the primary in about 1/4 of the cases is a major therapeutic challenge. However, because it involves extensive exploration and has an aggressive course, it has a poor response to chemotherapy. You have to undergo a lot of invasive tests to bring about, and it's a burden on the patients. But with the availability of molecular profiling, targeted chemotherapy can improve the prognosis of such patients. Thank you all for your patient hearing.